listos? Hello and welcome to another episode of our Oasis of Hope webinar with Dr. Contreras and Dr. Julio Valdez. If you give us just a couple of minutes while we begin, we're just waiting for everybody to join in. In the meantime, just want to make sure that our chat is working. If possible, could you give us a hello and your name and where you're from and where you're visiting us from? Well, joining us from, I'm sorry, so we can know where you are and where you're saying hi from. We have a very international audience, so if you can just tap in on the chats, where you're from. We have Pat from Michigan. Hello, Pat. How are you doing? Vijana from Naples, Florida. Dr. Hans from San Diego, local. Dr. Hans. Crystal from Texas, and Jerry from Geneva, New York. Oh, there's a lot of people. It's going too fast. Heidi from Canada. We have Wendell from Rochester. Mark from Los Angeles. Hello, everybody from Honolulu, from down in California, from Phoenix, from Tulsa, from North Cowichan, British Columbia. That's a very international audience. Yes. Yeah, we have Thomas from London. We have him from Australia, from New Zealand. Dr. Contreras. So. Well, why don't we get started? That's great. This is amazing. Well, my name is Gaston Pesada. I'm the director here at Oasis of Hope Hospital, and I'm joined today with Dr. Francisco Contreras, President and Medical Director here at the Oasis of Hope, and Dr. Julio Valdez, one of our attending physicians and very recognized and distinguished member of our medical staff. And today's webinar is about metabolic weaknesses that every cancer shares. And we're going to get started with a presentation from Dr. Contreras and Dr. Valdez about the 10 common weaknesses that all metabolic weaknesses that all cancers share. And while we get started, thank you again for joining us. Oasis of Hope Hospital has been operating since 1963, for 60 plus years now, and we have served over 100,000 patients from over 50 nations around there. We have patients from all over the world, which is amazing. And we'll get started with today's topic. And I'll let Dr. Contreras take it away.
Well, there's no question that cancer is definitely a genetic disease by the fact that it arises from mutations of the cells and mutations of the DNA. And when our immune system cannot get rid of these cells, they can cluster together and form a tumor. And so the origin is definitely a genetic. It's not necessarily hereditary, but it is genetic. But on the other side, these genetic mutations will cause a number of metabolic impacts on the body and on the tumor. And so these are some of the common denominating metabolic factors that cancers share that we can use to undermine the activity of cancer and in many cases destroy it. Well, the first thing is that when these mutations happen, the cells will turn from aerobic, from being dependent on oxygen, to being independent of oxygen. And these causes a number of problems in their metabolism. Again, that once we know this, we can exploit them. The first one is that they're hypoxic. Regardless of what cancer it is, it doesn't matter where it comes from, they are all hypoxic. Then because they're hypoxic, they will use a different pathway to obtain energy. Because the normal cells, when they obtain energy, they use oxygen. And in the presence of oxygen, the conversion of, for instance, carbohydrates into ATP or energy is a fairly easy and straightforward process. So for any unit of carbohydrates, for instance, the cell will convert them into 32 units of energy. And the waste material of this conversion is water and CO2. Water we excrete through the urine, and CO2 we excrete while we exhale. The second part that happens with this is that malignant cells, because there is no oxygen, they will then convert for every unit of carbohydrates or sugar, they will convert it into 2 units of energy instead of 32. So it's a very inefficient way of obtaining energy, and thus all cancer cells, regardless of whether it's cancer of the breast, cancer of the colon, cancer of the stomach, they all produce very little energy from carbohydrates, and they become bullies for sugar. So they crave sugar tremendously in order to provide the amount of energy that they need to grow. And here, in contrast with the waste materials from the normal process of obtaining energy in the presence of oxygen, the waste material is lactic acid. And so all malignant cells, all malignant tissues become acidic in comparison to the normal tissues that are surrounding the tumor. Another common denominating factor in cancer patients is that in order for all of these problems to happen, as I mentioned at the beginning, is that they have a weak immune system. And the main thing that is found in cancer patients is that all of them have low counts of dendritic cells. They have low counts of natural killer cells. And not only they have low counts of these immune system elements, they also have what are called tolerogenic capacity, meaning they tolerate these cancer cells to grow. They don't see them. So that's another common denominating factor. Another one is that cells grow, normal cells grow very insidiously and organized, and the tissues are very well structured, while malignant tumors grow very fast, very unorganized, and they have a very convoluted system of vessels to provide energy. So the blood that flows in and the blood that flows out do not have a very good passage, and this causes a problem in them because our circulatory system works as like a radiator, is the one that controls the temperature. And so all malignant cells have, or tissues, have difficulty getting rid of heat. And so you can exploit that with hyperthermia, for instance, because normal cells can withstand very high temperatures, whereas malignant cells cannot. Another difference between the normal cells and the malignant cells is what we call redox. So malignant cells do not feel comfortable in the normal reduction and oxidation levels. So the normal cells are always neutral. Malignant cells, the sweet spot where they feel very comfortable. Their comfort zone is in oxidation. So regardless of whether it's a sarcoma or a melanoma or a carcinoma or a squamous cell carcinoma, they all live in this comfort zone of oxidation. Another common denominating factor, I don't know how many I've mentioned, I don't know if there are 10 or less, but I'll stop with this one.
Yes.
And then we can go into how to exploit them. That was found for a while, since the cells live in oxidation. The first one that came with an idea on how to kill cancer by exploiting this was Linus Pauling, that said, well, if the cells live in oxidation, why don't we antioxidate the environment and thus kill the tumor. And so he's the first one to came up with the idea of using high dosages of vitamin C. There were some good results in the 70s, but not as good as expected. And for a while, many oncologists felt that it was not worth doing this high dose vitamin C. And then on top of that, of this, another common denominating factor that was found is that most malignant tumors had low levels of catalase. And so the killing agent of oxidating cells is not to antioxidate them, but oxidate them more. So oxidative stress is a way to kill cancer cells and not antioxidants. So then vitamin C for a long time went through the wayside until very recently. Doctors at the NIH and the NCI found out that you actually can convert vitamin C into an oxidant within a tumor cell in the presence of oxygen, and that is a little bit more complicated. But the fact is that all cells, malignant cells, are in oxidation, and that in order to kill them, you need to stress the oxidation even more. And so these common denominating factors can be exploited very effectively to kill cancer, or at least make it more liable so that other therapies can destroy the tumors. So maybe with that explanation.
Something that I would also like to add to the list of elements is the resistant cell death.
Yes.
When a cancer cell becomes a cancer cell, it also becomes pseudo-immortal. A cancer cell never dies unless you do something about it. And that's something that we target here with the home protocol, especially with the metformin, which helps inhibit the main pathway that makes the cancer cells immortal, especially targeting the cancer stem cells.
That's a very, very good point. The actual cell is not immortal because they do die, but the cell line never dies. This has been proven in many laboratory tests. What do we mean by this? Every cell in our organism has a caducity. How do you say?
Conducive?
Yeah,
Caducity?
Shelf life.
Life expectancy.
Life expectancy. And so, for instance, red blood cells, they have a life expectancy of about 120 days. And it goes from some days to many, many years. Every tissue in our system has a shelf life. Malignant cells do not. And so you can exploit this by inviting them to commit suicide. and so the technical name for caducity or shelf life or life expectancy is apoptosis. Malignant cells do not have that. They have no apoptosis, so you have to induce that in order to kill them. That's a very good point. Well, maybe we can open to questions.
We're gonna open up the before that, thank you very much. That was a great explanation of weaknesses for metabolic weaknesses for cancer. We're gonna open up our webinar for live Q&A. So in the webinar chat or in the Q&A section, go ahead and begin inputting your questions for Dr. Contreras or Dr. Julio. In the meantime, I want to thank you guys for joining us. It's been very interesting, especially about the cell lining. I mean, it was something I've worked here for 18 years. I've never heard that before. And thank you so much. So we're going to start off with, I think Mark Paget is asking, I am doing 2 vitamin C high dose, 2 vitamin C high dose from cassava. Should I stay on it? I have breast cancer, 1 metastasis on ilium bone.
Okay, so vitamin C in very high dosages have proven to be oxidative and not antioxidative. And so I'll explain a little bit about this because it's kind of counterintuitive to say, well, how can the best antioxidating agent now will be used as an oxidative? Well, researchers at the NIH discovered that in very high dosages, within the tumor, in the presence of oxygen, the vitamin C will convert itself into an oxidant, very similar to killing cancer cells like radiation therapy. So all radiation therapy kills cancer cells through oxidative stress. And so it has been proven that at very high dosages, vitamin C can convert into an oxidant and will oxidate or cause oxidative stress to cancer cells and kill them, similar to many chemotherapeutical agents that are oxidative in nature. So yes, I recommend for you to continue with your vitamin C therapy in high dosages, as long as it's well done, because if the therapist doesn't know what they're doing, and many do not, this oxidative stress will not happen, and you will not get the benefit. So one tip that I'm going to give you for you to ask a question of the therapies that are giving it to you is how fast they're giving the vitamin C. If the vitamin C is not given at a gram per minute, very likely you're going to have no effect. There are several other things that need to happen, but just as the first question, if you're receiving 50 grams and they're giving it to you in 2 or 3 hours, it's of no value as an oxidative therapy. Okay, it has to be given in 50 minutes. Otherwise, you don't get the concentration sufficient in your plasma to make this conversion from antioxidant into an oxidant. So find out about this, and if they're doing that, most likely they're doing the other things that are necessary to convert the vitamin C into an oxidative stress therapy.
Thank you for that. If you're experiencing any audio issues, please let us know so we can fix that technically. Thank you so much. Let me see. We got a lot of, yeah. Pat is asking, do you recommend RGCC testing to see what drugs, supplements are most effective? I know that's a common question we get.
We used to do it quite a bit a few years ago, and unfortunately we did not find a correlation between the recommendations from the test and the positive impact on the patient. And so we stopped using it because it's very expensive. With the experience that we have, we usually give the patient a better option or design a better therapy based on our experience than on what the test will say. It may be that by now it has improved some, but generally we have a lot of experience and we can design a therapy for our patients.
Something that I say sometimes to the patients too is that they're testing one single agent against the cancer on an isolated environment. So it's very hard to test a synergistic effect like we do here. So that's another thing with the...
That's a very good point. So one of our doctors here, his way of explaining this is that we bunch up against the cancer.
Yeah.
We hit it from many different angles. So that's why in many cases, one element wouldn't be effective, but in combination with the other ones, it becomes synergistic. And the results can be very positive.
Perfect. Dr. Julio, can you fix your just because it was brushing against your there you go. I think that's, just pull it in if you can. Put it, yeah, there you go. Perfect. All right. Thank you so much. Thank you so much for the comments. We're fixing everything. Okay. Will an alkaline diet help? Paulette is asking.
That's a very good question. I think that alkaline diets are good, but I mentioned that tumors have a low pH, they're acidic. And so many health professionals came to the conclusion, well, if the tumors are acidic, then an alkaline therapy should be beneficial to a patient. It's not in that sense, okay? No matter how much alkaline foods or elements you consume, the pH of the tumor is not going to change. And the pH of your body will not change either. The buffering system of our body is one of the most incredible feats of God in His creation. So no matter how much acids or alkalines you consume, your pH is going to be very stable. The example that I like to give here is that for 1 bottle of Coca-Cola, to neutralize the pH, to buffer the pH to 7, it takes 10 gallons of water. You can do it at home. It's an interesting thing. So how come if we drink a Coca-Cola not followed by 10 gallons of water, we do not die? Because our system will buffer it immediately. And on the other hand, no matter how much alkaline stuffs you consume, the pH of your body is going to stay stable. Now, one way to look at it this way, and why alkaline diet would be beneficial to you, is because we consume a tremendous amount of processed foods. And processed foods, in order to have a long shelf life, they put acids, because bugs do not like acids. And so we consume tremendous amount of acids, and we're stressing our buffering system all the time. So the more alkaline stuffs you consume, the more you're going to help out this system. So I view it like this: in your metabolic bank, when you consume acidic foods, it's like taking money out of the bank. And when you consume alkaline stuffs, you are putting money into your bank account. So it is a good idea to consume alkaline diets, but they will do nothing to change the pH of the tumor. The only proven things, there are 2 things that have proven to be effective in changing the pH of the tumor. One is omeprazole. It's a drug that people take when they have gastritis. I don't recommend it because it can have some side effects, long-term use. And the other one is baking soda. So baking soda has proven to actually affect the pH of the tumors in elevating the pH. And the less acidic a tumor tissue is, the more liable it becomes, to the point that you can actually kill it. So, this is a long explanation, but I just wanted to clarify that. Yes, it's a good idea to consume alkaline foods because we mostly consume acidic foods, but it's not going to change the pH of the tumor. Omeprazole and baking soda will. And so, for instance, all of our patients, we recommend them to take the baking soda.
Perfect. Thank you. It's a good question here. How precise are you with beating sarcoma tumors?
That's a good question. Sarcomas are very difficult. They're very aggressive type of tumors. They're very resilient. And for a long time, we did not accept patients with sarcomas because our results were not good. But with the advent of IMPACT, or our immune personalized autologous cell therapy based on dendritic cells, we have seen very, very encouraging results. Right now, I don't know if our patient with the sarcoma just left.
He just left, yeah.
Just left. But this is a young man,
20,
with a very aggressive sarcoma that we started treating 6 months ago, and he had only a few weeks to live. He's still alive after 6 months and very stable, with a tendency to improve because of this therapy. So even though sarcomas are very difficult to treat, they're very aggressive, with the advent of the IMPACT therapy, our dendritic cell-based therapies, we have been able to help now sarcoma patients, whereas in the past we had not. So we are now accepting patients with sarcomas of whatever type. There are some that are more aggressive than others. For instance, chondrosarcomas are less aggressive than osteosarcomas, and so on and so forth. But yes, now we do treat patients with sarcomas.
Perfect, perfect. We have a couple questions on fruits, berries, and sugars. Difference between good sugars and bad sugars.
Tumors, talking about tumors, not what is good for you health-wise, okay? Because it's obvious that the natural foods are going to be better than unnatural foods. Yeah. But the tumor does not care if the sugar comes from a banana or an ice cream. It's going to take advantage of it. So the diet for a cancer patient ideally should be low glycemic. And berries are low glycemic, even though they have sugar. And so it's one of the elements that we do give to our patients. So on the broad spectrum, the more you consume natural, organically grown foods, the better it's going to be for you. There's no question about it. But the tumors really don't care where the sugar comes from.
Okay. Yeah, a lot of questions on sugar and fruits and berries. So thank you for sharing that, Dr. Contreras. Good question by Dr. John Montalvo. Will a combination of amygdalin and high-dose vitamin C work in destroying cancer? I know you touched upon that in your presentation, so maybe you can
definitely. And here is this part of bunching up. Because vitamin C works through an oxidative stress, whereas vitamin B17 or laetral or amygdalin has a completely different mode of action. Amygdalin kills malignant cells through poisoning with cyanide. Now, this was one of the main reasons why so many scientists pushed against amygdalin, but they don't take into account that we need actually cyanide to survive. Cyanide is one of the raw materials for the production of cyanocobalamin, which is vitamin B12. And so about 1,200 foods normally, naturally are available to us that contain very small amounts of cyanide precisely for this purpose. What happens is that malignant cells do not have the enzymes necessary to convert the cyanide into cyanocobalamin, and malignant cells tend to not have these enzymes, and so very specifically, amygdalin will kill cells with these conditions, which are the malignant cells. So they very specifically kill malignant cells. So amygdalin is a mild anti-tumor agent that is completely natural, and that in combination with other killing agents will do a synergistic effect. So yes, doctor, we would combine, and we combine, in fact, in all of our patients here, the high-dose vitamin C and the use of B17, which is actually not a vitamin. It was misnomed in the 50s, I think, by the famous doctors Krebs, son and father. Interestingly, for those of you that speak German, Krebs means cancer in
Dr.
English.
Cancer.
So they were doctor
cancer.
Yeah, doctors cancer. And they're the ones that actually were seeking for an element that would cure cancer, and they found a tribe in the Himalayas called the Hansa that have the lowest incidence of cancer in the world, and so that's how they discovered amygdalin, and they thought that it was a derivative of the B vitamin complex, but it isn't. But the name stuck, and just about everybody knows amygdalin or laetral as vitamin B17.
Yeah, something I would like to add to that is that the vitamin C and the B17 are part of the whole combination of elements that we do here. Like, it's not just vitamin C, it's not just B17. We will work with the hyperthermia, we work with the impact, which is always improving. Yes. So it's not just about just giving B17, right? There are some patients.
immunotherapy and the metabolic therapy.
Yeah, that's the approach that we had to. It has to be thorough, it has to be enhanced, it has to be a combination with a home protocol too. Okay, so we don't put all of our eggs in the same basket.
Yes.
Kind of amazing because I've been working here for 18 years, and I can remember that a lot of the elements we used to give back then, we don't give anymore. But a lot of the same ones we still do.
Yeah.
It's always constantly evolving. And
Yes.
Yes.
new treatments come in. We always try to see which ones are going to work, which ones have great benefit for the patient. Cost-wise, also is always something that we take into consideration. So that's very interesting.
Yeah, we never stop
Innovating.
Innovating.
Digging into the
Yeah.
into the science.
Yes.
And so there's a tremendous amount of evolution in the scientific
Yeah.
realm that helps us decide what to give and what not to give, or what to continue and not to continue.
Exactly, and that's where the immunotherapy has really shined.
Yes.
Lately with
Yes.
the direct cell-based immunotherapy that we have here at Oasis. So yes, continuing on. This is a question we're getting more often in interested patients that want to come to Oasis. Cancer stem cells. And we're curiously going to the Beljanski conference at the end of the month, and one of the big topics there is cancer stem cells. And Tracy's asking, when there is no evidence of disease, are there dormant cancer stem cells? Is it possible to eradicate them? And I know that part of the home care treatment program is directed towards
Yes.
dormant cancer stem cells. So I don't know if you want to.
That was the main thing I was talking about a moment ago about the metformin. Cancer stem cells are rich on a pathway which is called mTOR1. Back in the 2009, they were doing some tests on cancer patients, giving them chemotherapies, and they saw that the arm of patients who were doing chemotherapy and were diabetic were doing better than the rest of the patients. So they started looking deeper into the interaction between the diabetic medications and cancer. And that's when they found the metformin. Most cancer patients who were diabetic and were doing better were taking metformin. And that's when they saw that weakness in the armor of cancer in regards to the cancer stem cells. And that's what we give to the patients several years worth of metformin treatment after they are expected to be cancer-free. Something that Dr. Contreras always talks about is about no evidence of disease, or the term remission, right? We don't stop when we expect remission. We keep giving the treatments, we keep giving the dendritic cell vaccine to keep targeting those stem cells too.
And what have you studied on these new, or not so new, Beljanski, from Dr. Beljanski, that in France he has been working with a couple of elements.
Yes.
That and they've done studies that show that they actually kill stem cells as well. Because chemotherapy, just to explain to the public that's listening to us, chemotherapy generally will not kill stem cells, nor radiation therapy. And so that's why you can eradicate a tumor, and then you will have recurrences when there was no evidence of disease, and it's because these cells are still there.
Yeah. Well, Dr. Mirko Beljanski discovered two elements, pauperia and Rarwolfia vomitoria, which have effects. Recently, they have been discovered as having effects against cancer stem cells. By inhibiting other pathways based on something called AMPK, which is one of the main pathways that help the cancer reduce the oxidation inside of the cancer cell. So by targeting that, he can increase the oxidation also in an indirect way and improve the survival of cancer patients. They have research about pancreas cancer, they have the research about prostatic cancer, breast cancer, ovarian cancer, with very promising results so far.
And that's why we are, as we just mentioned a few minutes ago, that we're always looking into the literature. And so one of the aims that Dr. Julio is trying to convince the rest of the group here is that we may use these elements because they're natural, they're not drugs, in comparison to the metformin. Although metformin is a very well-known drug, it's probably the drug most used in the world. Still, a good number of our patients are intolerant to it.
Yes.
Because it may cause diarrhea,
Gastrointestinal side effects.
And so I would say, what, 25, 30% of
20 to
patients
30, yes.
cannot take it. So we could start by giving these new elements, to our patients, and in the hope that maybe then we will stop the metformin altogether and use these products in the near future.
Perfect. That's great information. Thank you. That's great information. Quick lightning round. Let's do it. Membendazole, fenbendazole, and ivermectin. We had a lot of questions on that.
I leave Dr. Julio, he's the expert.
Well, that's part of the innovation that we've been trying to do so far. Mebendazole, fenbendazole, and ivermectin are not yet part of the protocol, the standard protocol that we give here. We're working on doing it as a reinforcement to the prior protocols in case we need a patient to improve or to make any changes, especially with the new vaccines that we're doing. But we're working to adding it to the few patients in the future. We've seen some promising situations with patients who were doing chemotherapy. They were doing pretty bad with side effects, and when they started doing Femben or ivermectin, they started feeling better. So we're delving into that combination of elements for the future. Okay. I think the combination of pulpuraria, Wolfia vomitoria, mebendazole and fenbendazole, it's gonna be pretty beneficial.
Great. Thank you so much for that.
Sorry about that, somebody's calling me.
Work never stops here at Oasis. Work never stops. Cryoablation.
Cryoablation?
Yeah. Do we
Let me
it?
just mention a little bit more on this
Parasitic
anti-parasitic drugs. There's no question that there is some anti-tumor effect, no question about it. And there's quite a bit of information now because fenbendazole and mebendazole have been used for a long time, and so in those elements we have a lot more information. Ivermectin is newer. It became popular during the pandemic, and I believe that it's a very good element to use in patients with cancer. And one of the questions that scientists still have is the safety of using these drugs for long periods and very high dosages in comparison to the dosages that they were designed for. Very minute dosages, twice a year, right? And I just want to let you know that we did a study here at the hospital. When the pandemic came, most of us were against the vaccination. And in fact, a good number of us rejected the possibility of ever receiving that type of vaccine. So we did not want it to do that. And so we're about 100 here, employees at the Oasis of Hope. And I offered the personnel that instead of doing the vaccine, we could use the protocol that was designed with ivermectin for protection, for prevention of the disease. And I would say that more than 50% of us
I was one of those patients. So
decided not to do the vaccine, and we decided to use the ivermectin. So we used very high dosages of ivermectin, and we took it at least for 6 months. Most of us took it for 9 months. We did not get COVID, and we're still alive. So I can tell you that taking ivermectin in very high dosages, in comparison to what it was designed for a long time, 9 months to a year, will not provoke any negative side effect. And that's why we are definitely considering both of them, or each one of them separately, of these anti-parasitic drugs as a possible anti-tumor therapy within the program of the Oasis of Hope.
And by God's grace, we started working with an ex-FDA. He has a companion.
Yes.
He sent us a big amount of information about ivermectin, and that's how we started working even more into the the combination. We normally give the treatment in cycles, the same as we do here, 4 weeks of taking the medicine with a week of rest, and it's been proving pretty tolerable for the patients that we've been giving them so far.
Yes. So something happened to our cameras. I hope that the audio is fine.
Yeah, I think we got the second camera working, so we'll have the
Yeah.
first camera working
So
pretty soon.
this is starting to look like a very sophisticated
Movie studio, right?
Yeah.
where we have to look at the different cameras.
We're constantly evolving our, if you can't hear me, it's okay. So Werner is asking about cryoablation. I mean, that's something that we do get asked a lot, cryoablation. How does it work with that? But it's more for solid tumors, right?
Yes, it's only for solid tumors.
Yes.
And so cryoablation is the destruction of a tumor using extreme cold temperatures. And you achieve this by inserting a probe into the tumor, and a machine will cause this freezing of the tumor. And you can actually destroy the tumor completely with this low temperatures. There are several, let's say, pros and cons. The cons are that the largest tumor that you can ablate or destroy with this is about 5 centimeters.
2 inches.
About 2 inches. And if you have many tumors, it's just very difficult to poke the patient in so many places. So the ideal is patients that have 1 tumor or 2 tumors that are smaller than that, and you can destroy them. The advantage, the big advantage is when you can do that is not only that you destroy the tumors, but it actually works as a vaccination. It promotes a very positive immune response against whatever tumor cells may be floating around or tumors elsewhere. Whereas ablation with radiofrequency, for instance, or with high temperatures, which are also available, will not provoke that immune response. So if you're going to use ablation, I recommend cryoablation over the other type of ablations that you have.
Which is
Here
just
at
ablation.
Yes, ablation just means destruction of the tumor.
Yeah.
And
Through
you can
heat,
destroy it with
electricity.
yeah.
Okay.
And so cryo would be the best. We do not have cryoablation here at the Oasis. We've done it many times. There are groups that will come with their equipment and do it. It's just very expensive, and because the type of patients that come to us come with massive amounts of tumor activity, where really very few of our patients will be good candidates for cryoablation.
It's mainly for stage 1 or
Yes.
2.
But it is a good possibility for patients with very low tumor load in early stages, and we do recommend it.
Perfect. There's a question about EBU, and it says anonymous. So IV ozone therapy / EBU, and a new kind of, not new, but more modern kind of ozone therapy called 10-pass. I don't know if
Yes,
you've heard of that.
yes.
So maybe you can explain the differences
Well,
and the effects of each.
By the way, Dr. Julio is our expert
Yeah.
in ozone therapy.
The basis of the ozone therapy, it's all about the dosage that you get to the patient. Okay, we have something called major autohemotherapy, which is drawing blood from the patient, 1.2 milliliters per kilogram, and ozonated, depending on the patient, 40 micrograms per milliliter, so different concentrations of it, and then put the blood back to the patient. There's a very interesting effect when you do that ozone therapy, in which Dr. Contreras, you have seen it.
Yeah.
You draw the blood is all dark, and when you apply the ozone, it becomes a very bright red, and then that's what you apply back to the patient. There's also the EBU therapy, which is something that we've been doing so far. It's something similar to the hemodialysis machine. We are filtering the blood, and we are putting ozone in it at the same time. Through that way, we can ozonate up to 2 liters of blood, depending on the patient tolerance, up to 50 minutes of treatment. We were the first patients,
Yes.
one of the first patients to try it here. And there's also the multi-pass. The multi-pass, or 10-pass, it's a modified form of ozone therapy in which you put a closed circuit, you draw the blood never goes out of your body really, it gets ozonated inside of a little egg, and then they put it back on you, and they repeat the process.
Is it extra
several,
or is it is it one
it goes,
Yeah.
it's one line.
One line, okay.
Yes, it goes all out and then back again. Okay, that way they can do a treatment which is going to be stronger than the major autohemotherapy, but I would say a little weaker than the EVU treatment. I would see it as a very good option, especially for patients who don't want to get the blood taken out.
Especially like Jehovah's Witnesses.
Jehovah's Witnesses, it can be a beneficial treatment because that can be a good way to.
That is something that they would
do.
accept much easier than other types of.
The blood never really leaves the body.
But in general, the amount of ozone is very similar in all of them, right?
It all depends. I think the higher one is the EVU.
The
That's
EVU?
about twice or 3 times more than the major autohemotherapy. And the multi-pass depends on the concentration that you do it. It can be up to 1.5, the normal amount.
Okay. So and there are benefits of ozonating the blood more than less?
Well, it all depends on the target you want. If we're treating cancer, I would say the more you do it, the better.
Okay.
Yes.
And one of the reasons for that is, again, oxidative stress.
Yes.
And so tumors are liable to oxidative stress.
Great. And we have a question from Terry. If I come to Oasis of Hope, are you the only oncologist? That's the
No.
only surgical oncologist.
I'm the surgical oncologist. We have in staff also a clinical oncologist, and whenever necessary, we can bring. We have radiation oncologists that work with
Hematologists.
us. Hematologists that work with us. We have urologists, oncologists, and now there are many specialties. So we have them all available here at the Oasis.
Perfect. This is time's flying by.
Yes.
How about a lot of questions about baking soda? Taking baking soda. I mean, I think it was from the alkaline.
Yes.
Yeah.
That question. I don't know if you want to attack
As
that.
part of the home protocol, we give a combination of baking soda. Some patients try to drink it all at the same time. But what we normally recommend is 2 teaspoons of baking soda, 16 ounces of water, about this amount, and you drink it during the day in order to get the benefits that Dr. Contreras was speaking about, increasing your bank account against cancer, decreasing the tumor microenvironment's acidity, and improving the activity of the immune system against it.
Great. Mark's asking about NK cell therapy. Can you explain a little bit about how that
NK stands for natural killer cells, and natural killer cells are part of the immune system. They're part of the T cells, and they are specialized in killing cancer cells and viruses. And so at the beginning I mentioned that one of the common denominating factors of patients with cancer is that they have low counts of NKs, and they have a low count and they are inactive on top of it. So activating NKs and increasing the amount of NKs is a big part of our impact therapy or our immune therapy here at the Oasis of Hope.
And there's the news about the medication that we're using now to increase the harvest of the white blood cells in general. We've been doing a combination of Neupogen before the harvesting of the cells to improve. We've been seeing increases of up to 50 to 100% compared to the prior tests that we were measuring before.
Yes.
So that's also increasing the number of NK cells in your body.
So what he's talking about is that most cancer patients come to us with low blood counts. And obviously the immune system is basically from the white cells. There are other elements, okay, very important for the immune system, but we're talking about white cells. And the family of white cells that we need to increase is monocytes and the T cells. And from them is that where we're going to create these immune therapies. So patients that have had a lot of chemotherapy have very low counts. And so our average number of dendritic cells and NK cells that we were harvesting from the patients and expanding was about 10 million. Now with the use of Neupogen before the draw of the blood to produce the immune therapy, we're getting counts up to 20, even we had one patient with 40 million very recently. So we've made now the decision to provide this therapy to increase the blood counts in all of our patients, because then the strength of the immunotherapy is going to be potentialized.
Yeah, so the more white blood cell count you have, the stronger the immune therapy,
Yes.
the immune cell
Correct.
therapy.
Because of the amount, in numbers.
The more we can harvest, the better.
Yeah, the
So
better.
harvest, expand, and reinfuse back into the
Correct.
patient.
Yes.
Yeah, so if you have any questions about our impact program, which has, we've seen amazing results.
Yeah.
We're constantly we're constantly doing the TILs pretty soon with NKs, the lysates. We're activating the cells in different ways, and we're promoting immune stimulation so we can harvest more amounts of white blood cells. So it's the interesting times at Oasis.
Yes.
Yeah,
Yes.
It's a very, very interesting times. And all right, so Angel is asking dendritic cell-based therapy for multiple myeloma. I know that we're doing it now for
Yes.
blood cancers, right? Yes.
We were not doing any immune therapy for blood circulating tumors, but now, thanks to the development of our personnel in the immuno laboratory, they've become so good that now they're actually developing cell therapies based on dendritic cells for patients with circulating tumors, especially multiple myelomas and some leukemias.
Amazing, amazing, amazing. Karen has a very specific question. She's asking, I currently have stage 4 kidney cancer with multimodal disease, 5 tumors on a solitary kidney, and met to the right abdominal wall and the posterior ischium. My local doctor is encouraging me to consider a therapeutic ketogenic diet. Do you think this will be helpful for my case? Since in 2021 initial diagnosis, I have eaten whole foods, plant-based with lean animal protein.
Yes. The ketogenic diet for cancer patients is different than the ketogenic diet for people that want to lose weight. Okay, so the ketogenic diet for cancer patients is very complicated. It's fats only, 0 protein, 0 carbohydrates. We did a clinical study here, and I can tell you that it is just very difficult to do. Not impossible, and I do believe that it could be very helpful to you. There are studies that show, especially in brain tumors, which are more aggressive than kidney tumors, and kidney malignancy is aggressive enough. So if you can do it, I think it would be very good for you. But no protein, no carbohydrates, just fats. Try it. I think it would be beneficial to you.
Okay, Michelle, the medication to increase the blood count is called Neupogen. Neupogen. Okay, and let me see. Okay, there was a question about the. Let me see. How about taking bitter apricot seeds, I imagine for the vitamin B17? What would be the proper dose for a stage 4 prostate cancer patient?
You need at least 2 grams orally a day to have any impact on the tumor. And it takes about a pound of bitter almond seeds to get 500 milligrams. So you would need 4 pounds of seeds and it's impossible to take
day?
that amount a day.
Yeah, so, something I
They're
say.
very bitter, and they really will destroy your stomach. So, yes, you will get it, but the dosages would be minimal if you take, let's say, 20 kernels, which is what is recommended for most people that they can tolerate. And so I encourage you to find a product that has 50 or 500 milligrams per pill, or our products, which are
Yeah.
much more effective.
Yes, and we have a liposomal B17, which was tested. We were doing tests with the University of Mexico to see the concentration of amygdalin on the blood of the patients that were trying it. We were comparing the concentration with the IV versus the liposomal. And after the normal curve of elevation from the IV, we saw stable amounts of B17 in both groups. So both were about the same. So that's why you need a concentrated, specific medication with B17. No, the seeds are not. I tell the patients sometimes, that's why I say in my class, it's impossible for you to know how sweet an orange is going to be before you try it. So it's impossible to tell how much B17 you will be getting in each seed. So
yes.
you can either go too high, which is near impossible, or too low.
Yeah.
Right?
All right. Loretta's asking that she has stable chronic kidney disease, and she's in stage 4 for 9 years now. Would IPT work for her?
So it's confusing. Do you have stage 4 kidney failure?
I'm a stable chronic kidney disease person who has been in stage 4 for 9 years.
Because there's what is called stage 4 kidney failure. So our treatments will not help improve the kidney function. Now, if on top of having kidney failure, you have a stage 4 cancer of the kidney, so the question is very confusing. Could you please elaborate on the question?
She says she's diagnosed with carcinosarcoma.
Oh, okay. Carcinosarcoma in stage 4.
Yeah, stage 4, yeah.
Well, then if you have, on top of it, kidney failure, we would have to adjust our therapy because...
No kidney failure.
Oh, no kidney failure.
No kidney failure.
No, then you would be a good candidate for our therapy.
Yes.
And these are aggressive tumors.
Well,
carcinosarcomas.
9 years, it's a good.
But you've done really well if you've survived 9 years. And we've treated a good number of carcinosarcomas here at the Oasis of Hope with our impact therapy.
Okay, this is, I think, my favorite question by V. Lewin. Are you familiar with Dr. Patrick Zoon-Xiong, who was on Tucker? There it is.
Yes, we become very familiar with him after that interview.
Amazing interview, by the way. Amazing.
And yeah, I recommended that you look for it because he's been working with dendritic cell-based and T-cell-based cell therapies. And we've been doing this now for 15 years. So we are very interested in his work. But he's now, what he's talking about now is creating a preventive vaccine, which
It's unheard of.
Which is unheard of, okay? And I hope that he can get that thing done with this new administration in the United States, because that would really be a game changer.
Yeah.
In the fact that his T cells, of course, in the interview, he does not, profoundly go into the science. So we're now looking for all of his publications and studying them. But I would support him in every way possible if truly he can create a preventive vaccine for all cancers for all people. So that would be a tremendous blessing.
Yeah, because he's talking about increasing the amount of, unblinding the natural killer cells.
That we know, but that's a treatment.
As a treatment, yeah.
But
as a preventative
actually,
measure.
as a preventative measure, that's a major.
So even before you get,
you would
never
get
get cancer.
Maybe if you have a family history of cancer, you can take it sooner.
Mutation of a cell and it will kill it automatically.
Yeah, it's amazing.
It's amazing. So We're looking into it, and we're gathering, all his publications to know really what he's talking about. We know very well what he's talking about as far as treating the patients, because we've done that for many, many years with a lot of success. But the preventive element is very interesting to me.
Great, yeah, we've had a lot of talk, a lot of questions and a lot of conversation about that interview. It's heard around the world.
Yes.
Heard around the world. Couple more questions. We want to be very nice with Dr. Contreras' time, and Dr. Julio is a very busy people. Let me see, I got a good question here. Sorry about that, give me one quick second. Ivermectin, we discussed that. Chinese medicinal mushrooms.
Well, we've been working.
We use more
AHTC,
Japanese.
Japanese, yeah.
But obviously the Chinese have a lot of experience, and there's 5,000 years of experience with all of these things. And there's no question, especially with the ones that we studied from Japan, they definitely have an immune potential. And so we, as part of our protocol for our patients, we include mushrooms, medicinal mushrooms to our patients.
Whenever I speak to a patient and he tells me that he's taking any kind of mushrooms, I'm pretty open to it. The concentration of something called alpha glucosides and beta glucosides, it's high in mushrooms, and that's the main effect that the mushrooms have. I don't know if it depends on the kind of mushrooms or the country you get it from, but they have immune stimulating effects against cancer. So that's why we do recommend it. I'm telling you as much as you can take, as it's safe, it's okay.
Mushrooms get a bad name.
Yes.
Two more questions. Paulette is asking about Keytruda for immunotherapy.
So Keytruda is a targeted immunotherapy based on checkpoint inhibitors. And whenever we can combine the checkpoint inhibitors with our dendritic-based cell therapy, it's a good option. We don't use it very much here in Mexico because it's Keytruda is extremely expensive. Here in Mexico, it's about $10,000 every 3 weeks. But American patients that have insurance, and when the doctor is open to giving the patient Keytruda without chemo, then it's a good combination therapy for us. So in general, Keytruda is well tolerated, and in comparison to many of the other targeted therapies, some of them can be very harsh. Not as harsh as chemotherapy, but they do have intolerance issues. But Keytruda has proven to be quite effective and well tolerated. And whenever a patient has the mutation where he or she is a good candidate for Keytruda, we want to combine them.
Okay, and the great thing about Oasis and the doctors here is that they work, we get a lot of US-based patients, and they have private insurance back home.
Yes.
So if there's any treatments that we recommend that you can get back home, we recommend you getting it through insurance so that you won't have to pay for it down here, because it can be very expensive. So last question. Thank you so much for your time, doctors. Infrared therapy. What is our clinical experience with infrared therapy? I know that we use it together with our hyperthermia.
Well, I'll just say that I mentioned at the beginning that one of the common denominating factors is that tumors grow very fast and very unorganized, and that through hyperthermia you can actually kill malignant cells. That's one of the reasons why we use either infrared or just hyperthermia. In our hyperthermia cocoons actually have a combination of hyperthermia with red light therapy. But we can also use only
the infrared,
the infrared.
We've been working with the infrared light therapy. Yeah.
And here our main reason is because it provokes oxidative stress. And because in order to kill malignant cells, the patient has to be under the hyperthermia for a long, long time, and it's complicated to do. But infrared is something that you can use every day.
Yeah.
Even if you don't get to the point where it can cause oxidative stress, it is immune stimulating.
Yes, the first time we used it, I recall that there was a patient with a back surgery. And the back surgeon told us to put the patient under the infrared light therapy because it was going to decrease inflammation for the patient. So we've been working so far with very good experience with infrared light therapy.
Perfect. Well, thank you very much, Dr. Valdez and Dr. Contreras, for your time. Valuable information. We had patients, people joining us from all over the world. I just want to let you know that Oasis of Hope, we have admissions coordinators ready to take any of your calls, any questions you might have about how to become a patient at the hospital. Most of our patients fly into San Diego. We pick them up at the airport. We bring them down to the hospital. So the great thing about Oasis is that everything's under one roof. So you stay here, you eat here, we love you here, you get treated here. We're very Mexican, so we hug a lot. There's a lot of cancer wisdom running through the halls of Oasis, and we always have around 15 to 20 patients at any given time, all going through similar experiences. So the community that's created here at Oasis is something amazing. We are a Christian-based hospital, and we're not afraid to say it. It's a ministry. So anything you guys need in terms of our recommendations or our perspective about your condition, please call us. And we have admissions coordinators that can talk to you. We have a doctor that does Zoom calls and at no cost. So thank you very much from wherever you are joining us from. We thank you from the bottom of our hearts. God bless you, everybody. Have a good evening or good morning. And from Tijuana to the world, thank you for joining us and have an amazing night or day. Thank you.
Thank you.
God bless.